Hello, doctors. Today we are going to deal about the topic physiology of the menstrual cycle in detail. Now, why is this important? Because the menstrual cycle is like what you can say, like the foundation of female reproductive physiology, and it is not just about the monthly bleeding. It represents a what you can call is like a synchronized dialogue between the hypothalamus, pituitary, ovaries, and uterus. So, a normal cycle, when you're talking about the normal cycle, is like a 28 days on an average, but it can be anywhere between the 21 to 35 days. It is considered as a normal. So as a clinician, we need to understand this physiology because many of our OPD patients come with complaints of irregular cycles, infertility, or abnormal bleeding. And unless we know the physiology, the management becomes like a guesswork. So it is very important to know the physiology so that it will be easy for us to guide the patient, and also as well as to it will help us to manage the condition of the patient. So this is what a menstrual cycle is. So a menstrual cycle is a monthly sequence of a hormonal and physiological changes in females, and it is regulated by the hypothalamic, pituitary, and ovarian axis. So average cycle is like 28 days. It can be range from 21 to 35 days. So this is the basic introduction of what is a like menstrual cycle. Next, we'll talk about the phases of menstrual cycle. So, what are the different stages which we or the phases of the menstrual cycle? The cycle is divided into four phases, and each phase have a different functions and different process, and it is driven by different hormones as well. So, there are four phases: menstrual, follicular, ovulation, luteal. So menstrual phase, what happens? It is from the day 1 to 5. It is the shedding of the functional endometrium. Next comes the follicular phase. So from day 1 to 13, multiple follicles will grow, but one dominant follicle will emerge. So that is what happens in the follicular phase. And when talking about the ovulation phase, the ovulation phase is around day 14, and it is like triggered by the luteinizing hormone surge. And the last phase is the luteal phase, which will be ranging from the day 15 to day 28. So this luteal phase, what happens here, the corpus luteum produces the progesterone to prepare the endometrium for implantation. So this is the four phases of menstrual cycle, and this is the sequence, and this sequence repeats month after month in a healthy reproductive aged women. So this, for a healthy aged women, this is the sequence which happens in the month every month. So if there is any difference between all among these process of any variation in the or imbalance in between the phases, that can lead to many other conditions, for example like irregular periods, PCOS, PCOD, etc. So infertility, etc., etc. So this is the most important phases of menstrual cycle, and what are the process going on. First, let's discuss about the hormonal regulation in the hypothalamus. So, as I have mentioned, it is the regulation between the hypothalamus, pituitary, and ovarian. So, first, you should know what happens in the hypothalamus and what it does. So, hypothalamus is the master of regulator. We can call it like a master regulator. It secretes GnRH, GnRH, which will be in pulse mode, like in pulsatile manner, and this pulsatile release is the key to maintain a normal cycle. So if and one more thing is, it controls the hypothalamus controls the release of the pituitary hormones, and if GnRH is very low, it is too slow, then the follicular stimulating hormone will predominate. And if the GnRH is rapid, or if pulses are rapid, the luteinizing hormone will predominate. So this variation ensures the follicular growth in the first half, and the ovulation in the middle of the cycle. So this is the important part of the phase. Clinically, if GnRH secretion is impaired, for example, like in hypothalamic amenorrhea due to stress or weight loss, the cycle will simply stop. So this if that is because of the GnRH secretion, when it is impaired, this can happen. So that is the main point. You should be aware of the process or the physiology what happening in the hypothalamus also. So this is what the hormone regulation, what happens in the hypothalamus and what are the process going on in the hypothalamus. Next, we'll move on to the hormone regulation pituitary gland. So, under the pituitary gland, what the hormone regulation happens? So, the anterior pituitary responds to the GnRH, which is secreted from the hypothalamus, and releases the FSH and LH hormone. The FSH, that is the follicular stimulating hormone, helps in the follicular growth and estrogen secretion. So LH, what it does the ovulation, is essential for the ovulation and the corpus luteum formation, and also the progesterone secretion. Next comes the prolactin. So prolactin from the pituitary gland can disturb the cycle if elevated, because if there is an elevation of prolactin happens in the pituitary, it can lead to the suppression of the GnRH, which is produced by the hypothalamus. So in cases of hyperprolactinemia, you have to think about the GnRH suppression. So it is very important because it is one of the most important secondary causes of secondary amenorrhea in our like OPD basis. So whenever patient complains of secondary amenorrhea, you have to check the prolactin levels, whether it is high or low. So maybe hyperprolactinemia can be one of the causes of the secondary amenorrhea. So this is what the hormone regulation happening in the pituitary gland. Next comes the ovarian hormones. Talking about the ovarian hormones, the ovary produce the estrogen, progesterone and inhibin. So estrogen stimulates the endometrial proliferation and causes the development of secondary sexual characteristics or sexual features. What progesterone does, it prepares the endometrium for implantation and supports the early pregnancy. Next is the inhibin. Inhibin, what it does is it will give a negative feedback on FSH. It inhibits the FSH, that is the follicular stimulating hormone secretion, so that only one follicle becomes dominant. So if there is any disturbances here happening in the estrogen progesterone inhibin, it can lead to the causing of PCOS, luteal phase defect or irregular cycles. So this is the importance of ovarian hormone. So if there is any variations among these hormones, estrogen, progesterone and inhibin, it can lead to the PCOS conditions and other conditions like irregular cycles, periods, luteal phase defects, etc. So this is the importance of ovarian hormones in the physiology of menstrual cycle. So now we'll discuss about the phases, menstrual cycle phases one by one. What happens? The follicular phase, or ovarian phase, ovulation phase, and the luteal phase. First is the follicular phase, that is from the day 1 to day 30. In the follicular phase, the follicular stimulating hormone stimulates the growth of the multiple follicles. So one dominant follicle secretes the high levels of estrogen. So this estrogen has two effects. One is it thickens the endometrium, and through the negative feedback it reduces the FSH to prevent the multiple dominant follicles. So that is the two effects of the estrogen. So clinically, if in case if this follicular phase have any variations or imbalance there, women may present with an anovulatory cycles, means the women will not have an ovulation happening in the menstrual cycle, which is a common cause of infertility. Maybe like patients may have like a period, like they may have a irregular periods or missed periods, but ovulation might not happen in such conditions, like if there is any fail in this follicular phase. So that is the importance of the first phase, that is the follicular phase from day 1 to day 13. Moving on to the ovulation phase, that is approximately a day 14. So here what happens, once the estrogen reaches a critical point, the feedback becomes positive, leading to the LH surge. Means LH means the luteinizing hormone surge. So this LH surge is the important point of ovulation. So if in this ovulation doesn't have like in this ovulation, if LH surge is not present, that can be difficult for, that is the fertile window. So if it is not in this LH surge, if the couples do not have an have their time of like have a sexual contact, there can, that is a fertile window. So if they do not have a sexual relationship during that time, maybe they will not be able to conceive. So that is the important point, ovulation day, that is the fertile window. Here the Graafian follicle will rupture, releasing the oocyte. So clinically, this is the fertile window. We can detect the LH surge, urine kits. So you can use there are many urine kits available now to check the LH surge. Like we can also advise LH surge urine kits to check the LH, detect the LH surge like in cases of infertility treatment. So that we can understand whether the patient's body, there is a LH surge happening during the ovulation. So failure of this LH surge means the failure of ovulation, means the ovulation will not happen, and leading to the anovulation or PCOS like presentation. So this is the important phase of the menstrual cycle, that is the ovulation phase. Next comes the luteal phase, that is the day 15 to day 28. So after ovulation, the follicle becomes the corpus luteum, which secretes the progesterone. So progesterone stabilizes the endometrium, which will convert it into secretory phase and prepare it for the implantation. So if fertilization does not occur, what happens, the corpus luteum degenerates after 14 days. The progesterone will fall and the menstruation will begin. So this is what happens in the luteal phase, is the normal thing. So if pregnancy occurs, what happens, the HCG level will rise, rescues the corpus luteum and maintains the progesterone secretion until the placenta takes over. So luteal phase defect is the clinical condition where insufficient progesterone leads to recurrent miscarriages. So that is also important about the luteal phase. So this is what happening in the luteal phase, that is the third phase of the menstrual cycle. Next comes, we'll discuss about the endometrial changes. So during the physiology of menstrual cycle, there will be changes in the endometrium also. So what are these changes? So let us see how the endometrium changes during the cycle. Menstrual phase, what happens, the functional layer or the endometrium layer will shed. In the proliferative phase, under the estrogen, the glands become straight and the endometrium gets thickens. In the second phase, that is the secretory phase. So third phase, that is the secretory phase. Under this progesterone, the glands become tortuous and secretory, and the spiral arteries will be developed. So these are other things which are and changes happening in the endometrium in the menstrual phase, proliferative phase and secretory phase. So these endometrial changes are very important because the histology of endometrium can be used to confirm the ovulation. So this is the importance of endometrial changes when talking about the physiology of menstrual cycle. Next, we will discuss about the clinical correlation. So, as I have mentioned, if there is any difference between the hormonal imbalance or any imbalance or variations among the phases, it can lead to many disturbances. Now, the disturbances in this physiology manifest clinically, like you can say amenorrhea, absent periods, oligomenorrhea, infrequent cycles, polymenorrhea, too frequent cycles, so menorrhea, menorrhagia, heavy bleeding, dysmenorrhea, that is the dysmenorrhea is painful period. So most of these are the OPD level issues, but some like severe anemia, iron anemia from the menorrhagia, which will lead to the require of the hospitalization. So that is the importance of the clinical correlation of the menstrual cycle. So you should be aware of when the patient comes and tell you whether they have an absence of menses, or if they have the infrequent cycle, or heavy menstrual bleeding, or painful menstruation. These are the cases or conditions you can correlate clinically with the condition. So this is the important clinical correlations in the physiology of menstruation. Next, move forward to the clinical investigation. So, in a patient with a menstrual disorder, we should investigate the patient in a systematic way. First one is hormonal profile. So you should be dealing with the patient's hormonal profile. First one is FSH. You should know the levels of FSH, LH, estrogen, progesterone, prolactin, and thyroid function to diagnose the condition, to verify the condition levels. Next is the ultrasound pelvis to check the follicular development and endometrial thickness. Ultrasound pelvis is very important for the in the when basis of investigation. Next comes the endometrial biopsy. So only if it is indicated, you can go for endometrial biopsy. It is very important to assess the secretory versus the proliferative phases, which is very useful in cases of infertility. So these are the very important investigations, pinpoint investigations, whether to know whether the defect is at like hypothalamus or pituitary or ovary or the uterus. So this is the important clinical investigation in the menstrual cycle. Next, you can go for the OPD and versus IPD management. How you can clinically manage the conditions of the patient in the OPD basis as well as the IPD basis. So in OPD management, the most important things, we have to handle most menstrual complaints very in a conservative manner. First one is you have to take the detailed history and menstrual history of the patient, and according to that you have to advise the patient and counsel the patient. So first one is advise lifestyle modification in cases of stress and PCOS and all. Lifestyle modification is very important. For stress reduction, you can advise healthy diet, exercise, and weight control. Next, well, coming to the medical therapy, you can do the pharmacological management, which includes like a combined therapy like OCPs, oral contraceptive pills, NSAIDs for pain relief, and iron supplementation for anemia, or any hormonal therapy for any specific imbalances. So the majority of the patients improve the OPD based care. So majority of the conditions you can treat the patient in the OPD basis. So only if there is a condition which requires hospitalization, which are severe cases and all, you can advise the patient to get admitted in the hospital and get the treatment in the IPD basis. Moving on to the IPD management. So there are some cases which require immediate admission and IPD management. For example, a woman with severe anemia due to menorrhagia may need a blood transfusion. So in such cases and all, you can advise the patient to get admitted and get the management treatments in the IPD level. Next is the surgical option, so which includes DNC, hysteroscopy, polypectomy, and myomectomy, and all these are like if structural causes like fibroids and present and all, you can do the surgical treatment, surgical options in the IPD basis. When comes to the infertility treatment, so assisted reproductive technologies for infertility can be done in the IPD basis only. So IPD cases or IPD care is mainly for a severe and complicated cases. Majority of the low risk cases or low risk patient you can deal in the OPD basis itself. But IPD, you can, the complicated and severe cases which you think it is very required an IPD management, you can go for an IPD management as well. So this is what about the IPD and the OPD management of the cases, how you can deal with the menstrual disorder cases and the of the patient. Summarize our topic or the conclusion, first we'll go with a video. It's a simple representation of what happens in the menstrual cycle, the physiology of menstrual cycle in a very picturesque way. And in a video, as a video I have put it up, you can see the video.
The menstrual cycle begins with menstrual bleeding, marking the follicular phase's first day. When the follicular phase begins, levels of estrogen and progesterone are low. As a result, the top layer of the uterus's thickened lining break down and are shed, and menstrual bleeding occurs. About this time, the pituitary gland starts sending follicle-stimulating hormones to your ovaries, stimulating the development of 5 to 20 follicles in the ovaries. Each follicle contains an immature egg and produces estrogen. One follicle will soon begin to grow faster than others. This is called the dominant follicle. As the follicle grows, the levels of estrogen in the blood rise significantly. This increase in estrogen begins to inhibit the secretion of the follicle-stimulating hormone. The fall in follicle-stimulating hormone allows smaller follicles to die off. They are, in effect, starved of follicle-stimulating hormone. The increasing amount of estrogen in your body also ensures that the lining of your womb thickens with nutrients and blood. This is so that if you do get pregnant, the fertilized egg will have everything it needs to grow. The ovulatory phase begins with a rise in the levels of luteinizing hormone and follicle-stimulating hormone. The surge of the luteinizing hormone triggers one of the most prominent follicles to pop open and release its egg, which heads into the fallopian tube and starts its journey towards the uterus. Ovulation usually occurs 16 to 32 hours after the beginning of the surge, around day 14 of the menstrual cycle. During the luteal phase, the levels of the luteinizing hormone and follicle-stimulating hormone decrease. The ruptured follicle closes after releasing the egg and forms a corpus luteum, which produces estrogen and progesterone, which causes the lining of the uterus to thicken even more. If an egg is fertilized, progesterone supports early pregnancy. But if no fertilization occurs, the corpus luteum will break down between 9 and 11 days after ovulation. This results in a drop in estrogen and progesterone levels, bringing us back to the first stage of menstruation if no pregnancy has occurred.
So now I think you got a picture of how what happens and what is the process or the physiology of menstrual cycle, what happens there in the uterus, the endometrium, and the ovaries, the corpus luteum, etc. How the follicle hormones are present in estrogen hormones levels, etc. and everything. I guess you got a clear picture regarding that. So to summarize our today's topic, the menstrual cycle is like a finely balanced thing between the hypothalamus, pituitary, and ovaries and uterus. So understanding this physiology is very vital for managing patients with menstrual disorders, infertility, or abnormal bleeding. So as a doctor or a OBGYN or as a clinicians, once we master the physiology, management in both the OPD and IPD becomes very more logic and effective. So it's very important to know the physiology of the menstrual cycle. So this comes to the end of our topic, physiology of menstrual cycle. I hope you got an idea regarding the topic. Thank you so much for patient listening and have a great day.